to present a timeline for the management of peripheral nerve injuries. Peripheral nerve injuries need managing depending on the time at which they present, the extent of injury, the bed, whether there's scarring, and how proximal the nerve injury is and whether there's any potential for motor recovery. If a patient presents late, a nerve will have this amorphous fibrous tissue formation with scar, which needs debriding using this salami slicing technique under the microscope until there is fresh vesicular pouting, and this is a reconstructible nerve. Now inevitably with resection there becomes a gap, and that gap needs reconstructing, and typically one would use autologous sensory nerve grafting to deal with that gap. And this can be very effective in pure sensory and pure motor nerves, but is less effective in a mixed nerve. So this talk is going to concentrate on the different techniques that may be necessary in nerve reconstruction at different stages of presentation. So in the early phase after nerve injury, decompression is often necessary, and that's necessary to remove hematoma, stop the nerve injury from deepening, and to identify the lesion. Untreated nerve injuries will result in perineural scarring, which may tether the nerve, cause ischemia, and prevent recovery. And neurolysis as a treatment for pain, also to assess functional recovery and improve quality of sensation and motor recovery, is necessary, increasing in time up to about 12 months. Beyond this, it's fairly futile, although there are cases where I've undertaken neurolysis for nerve tether many years after the injury to relieve pain, but it very rarely results in good functional gains after 12 months. Direct repair is only really possible in the first few days or perhaps a couple of weeks after injury, and after debridement of the nerve ends, positioning may be necessary in order to get the nerve ends together by using flexion of adjacent joints. Nerve grafting, I believe, only has a role in the very early phase after nerve injury, and because the rate of regeneration slows and there's cell death exponentially over time following the nerve injury, nerve grafting should only really be undertaken in the early phase. With very proximal nerve injuries, one has to question the efficacy of nerve grafting at all, particularly where the time-distance phenomena means there will be no meaningful motor recovery. This is particularly true in proximal lower limb nerve injuries, but nerve grafting may have a role to play in preventing and reducing pain. Now, nerve transfer has a reliable functional gain in all patients for motor up to about 9 months. 9 months is my cut-off really, because at this stage there is still only a short distance of re-innovation into the denervated muscle, but for good functional gains one needs to undertake nerve transfer surgery by 9 months. Sensory transfers can be undertaken later, and in special circumstances with slow degenerative axonopathies due to cervical spondylosis, or in patients perhaps who've had a neuritis, then I think nerve transfer can be undertaken later as a salvage. But we are talking here about peripheral nerve injury. The role of tendon transfers and arthrodesis is generally something to be considered from 3 to 6 months onwards, once the deficit is established, is known, and the natural history is known, and these are really salvage options for dealing with deficits following nerve injury. Thank you very much.